Now that I've mentioned time, one of the aspects of time that is very relevant to the practice of environmental epidemiology, to environmental health research, is exposure timing. Let me sort of give a very conceptual example to convey how this is a challenging problem. My own interest lies in looking at early life programming, which is prenatal exposures and exposure soon after birth, and then looking at neurodevelopment and neurodegeneration. Even in a condition that is not rare, it's just what I call as low frequency. It is about 1 to 2% of the population, for example, autism spectrum disorders. And if the age of diagnosis is towards the later part of childhood, around 4 years or later, which is the reality for autism, to get 100 cases to study this prospectively, we would start off with 10,000 mother-child pairs. I'm not saying that's the only design, but that is one of the stronger designs that we would ideally want to adopt for our studies. This problem only gets bigger if we look at rare disorders, and I'll discuss ALS or Lou Gehrig's disease, where the latency is 50 years. One of the challenges of measuring fetal exposure arises from the fact that in most studies we have access to the mother, and therefore we measure the mother's biomarkers, but it would be wrong to assume that whatever we measure in the mother reflects fetal exposure, because different chemicals, different exposures are partitioned differently across the placenta. For example, lead passes fairly passively, so the mother's blood lead levels do reflect fetal exposure. Cadmium is largely blocked, and manganese is actively transported. Although it's an essential nutrient, too much of it can be neurotoxic. So these are different scenarios where mother's biomarkers give different levels of information, different quality of information. And of course, in large epidemiological efforts such as the ECHO cohort studies, we can't just routinely sample fetal tissue unless there's a clinical indication. So what do we do in studies that are of rare or low frequency outcome? We essentially recruit cases and controls, and we can do that fairly well with using population level controls. The problem still persists. How do we look back decades, in some cases, to that critical window which might exist prenatally? How do we go back in time and retrospectively create a time series data set? I won't go into the lab methods, but the idea behind tooth matrix biomarkers is fairly simple. If you look at this tree and look at the growth rings, for hundreds of years, we've been looking at these growth rings in trees and making assumptions about its history. We can count back to record its time. We can look at a certain growth ring, and if it's wide, we can assume that the growth of that tree it grew well that year. If it's a very narrow growth ring, something stunted the growth of that tree. Maybe it was a drought or something else. So we can make assumptions about the growth, and we can predict the past. Similar growth rings exist in teeth. They're of course much narrower, much smaller. They're about 2 microns or so in size, and therefore they're hard to visualize and even harder to map. That's not the only aspect of teeth that is very useful for studies like ECHO, that they have growth rings. In fact, all baby teeth start mineralizing prenatally, somewhere in the second trimester. So every time a child sheds a baby tooth, they're actually handing you fetal tissue, and every child is going to shed 20 teeth, so we have 20 opportunities for non-invasive collection. The other aspect of teeth is their chemistry. They're made up of this highly reactive substance known as hydroxyapatite, and that works to our advantage because we can capture many chemicals in hydroxyapatite. And later on, I'll give you examples from about 10 to 20,000 different chemical signatures that we have captured in teeth. So what does the tooth biomarker data look like? Here I'll show you an example of a chemical that has been well studied, and I have studied it very often, which is lead. So on the vertical axis, you have the intensity of lead exposure or lead levels in teeth, and they're normalized to calcium. On the horizontal axis, we have developmental time. So like I said, if you look at this dashed vertical line which represents birth, we go into the second trimester. And here we have built this fine scale temporal profile, a week-to-week profile going forward in time well into the first year of life. This tooth was given from one of Dr. Bob Wright's cohorts in Mexico. The child was about 10 years old. When you look at their blood lead levels, as you can see from the tooth lead levels around the age of 200 days, they look rather unremarkable. But they have had a history of high level of exposure just before birth, and this would be masked if all we did was collect blood levels later in childhood. So that is the advantage of measuring this highly temporally resolved history of exposure. We can pick up peaks in exposure that would otherwise be missed. But that's not all we are doing. I want to go back to this idea that time is very important. And later on, I'm going to show you two more examples where we use distributed lag models. But I didn't want to assume that everybody works with distributed lag models. They're still gaining in popularity. So I'm going to show you something that is easy for everyone to grasp here. This is again a study from Dr. Wright's cohort where we made a dynamic graph. On the vertical axis, we have a 7-year measure of IQ. It's an IQ subscale. And on the horizontal axis, we have manganese levels. This graph is going to move. So I'm going to talk as we move forward in this graph and show that prenatally, the association between manganese and IQ is a positive one. And around birth, you start seeing this leveling off. But soon after birth, something very interesting happens. The relationship inverts. So now we no longer have that positive association, but rather an inverse association with IQ. We have shown this in two studies, in the Mexico cohort that Dr. Wright runs and another cohort that he runs in Italy, and the association holds. This is a reproduced relationship that manganese is positively associated to neurodevelopment prenatally, but postnatally it inverts. However, the point here is that if we ignore exposure timing, let's say we were to grind up this whole tooth and get one average measure, we would completely miss this time-dependent relationship. And I was discussing and I was preparing for this talk with Chris Forrest. One of the pointers or the advice he gave me was that he's received feedback that the audience would like to know what all we can measure in teeth. I want to show you this, but put it in a framework of how we can analyze this data, what is the thought process behind using this data. I'm going to show you examples of what we can measure outside our body. And I already showed you an example of lead and manganese, what we're exposed to, whether we breathe it or we eat it or we drink it. What are the metabolites of those exposures internally, but also how our body responds to that exposure. And couple that with molecular phenotyping, and then finally correlate that with clinical phenotyping. So we are building this entire pathway from exposure to our response to how we clinically appear. The first and perhaps the area where most work has been done is elements, both essential and toxic elements. There are many papers that my group has published, but I would encourage everyone to look at the seminal papers that were published by Herb Needleman, Bellinger, Rabinowitz, and others. And I've highlighted the box in red for a good paper where you can start. And the reference list of that has many other papers by Herb Needleman. That's where much of the seminal work was done. And metals in teeth have been validated in rodent models, in human studies, in primate studies. There's many papers out there. More recently, my group has been working on generating temporal signatures of various organic chemicals. I want to acknowledge my colleague here, Syam Andra and Shyamali Dasayanke, who have developed this very nice, fully targeted, so fully quantitative method of measuring up to 150 to 200 organic targets, all in a single assay. Some of these are shown here. I won't read all of them out, but this is just a partial list. There's many more that they can measure, and we do it by trimester resolution. The fact that they can do it all from a single aliquot is something that's very important, and I will come back to that point after the next slide. Now, once you're measuring hundreds of organic compounds, unlike metals, validating them is not so easy. And to be honest, we'll never be able to take this traditional approach of validating one organic compound in teeth against some other matrix, because the half-life in teeth would be very different to, let's say, something that we are just all used to analyzing, like urine or blood. But for some of them, we do have some encouraging data. This is in the home cohort. I've been working with Kim Yolton and Joe Braun for quite a while on this. And we compared monoesters of some phthalates collected at the same time what we were extracting or removing from teeth. You can see there is some positive correlation. We also have that for another phthalate monoester. But this is just two amongst hundreds of targets. And frankly, I don't think this is the approach to validate every target that we find in teeth. Rather, my interest more is to see the association with the health outcome. Ultimately, if a biomarker of exposure accurately and consistently and reproducibly predicts a relationship with the outcome, there is something very useful happening here. But let's move to the next part of what we can do. So far, I've shown you elements and metals and targeted organics, but these days there's a real push towards exposomic or untargeted assays. And here I want to acknowledge my colleague, Dr. Lauren Petrick, and also I'm working with Doug Walker, who collaborates with many of you. This is just a subset of about 20,000 signatures that we can measure reliably. We pick up to 50,000 peaks, but not all of them are ones that we trust. So we filter them down to between 10 and 20,000 that we trust. And this is just an example of from that very large number. On the left, you will see perfluorocompounds, parabens, and phthalates, things that we are exposed to, things that I referred to earlier as our external exposome, and then their metabolites. And you will see the monoesters of phthalates as our internal exposure on the metabolites. But we also see some essential dietary compounds, the building blocks of our physiology. And on the right, in the purple column here, or purple square here, we see biological response pathway like arachidonic acid, which as you know, is linked to inflammation. So now we are able to build that pathway from exposure to metabolism to molecular phenotyping and biological response. And our aim is to link this to clinical outcomes, and I'll be sharing two examples in a while. There's one thing that I feel strongly about, which is innovation on the hardware side. I often look at my colleagues in genomics with envy, because the reason we went from it costing $10,000 and more to sequence one individual's genome to now do it for a few $100s is because hardware was developed specifically for genomics. But when it comes to hardware for environmental sciences, my experience has been different. When I first started working for mass specs, I realized that their history was that they were developed for chemistry research and pharmacology research. Only later, almost a decade later, adapted to environmental sciences. When I first started using laser ablation technology at the end of the 1990s, early 2000s, it all existed in geology. There were people who were who wanted to study diamonds and laser ablate diamonds. They had very little interest in health outcomes. So I would often struggle in finding labs that would have a laser ablation system. And in reality, most of my PhD was done from 7 in the evening till 5 in the morning, because that was about the only time I could get access to these very expensive instruments that nobody wanted or nobody foresaw the utility in healthcare. The reason I'm going on about this point is that I believe we're at an inflection point where we must build our own hardware, and that's what my team has been doing. We are working in partnership with several private firms we've finalized a first-in-class laser ablation system, which just blows our current systems out of the water. We'll be picking up thousands and thousands of signatures. We are onto the second version of a robotic platform that micro-dissects along the growth rings in teeth and can do all this high-throughput automated sample analysis. The key to this is that we never grind up teeth. We don't grind them into a powder. We don't grind them into a thin wafer. We don't waste any material. Those, in my opinion, I have serious ethical concerns about using up material like that, which cannot be replaced. It's not like a urine sample where you can get another one. All right, I hope I've given you a picture of what all can be measured. And I hope that generates some collaborations. Everybody will have their set of exposures that are of interest to them and are of need in their cohort. But I would like to present two examples, one from early life and one from later life. Both are complex disorders in the meaning that we don't really understand their etiology, and genomics alone hasn't given us a clear picture of this. So there's definitely a need to bring in the environmental component. The first is autism spectrum disorder. Both these papers have been published, so I'll be skimming through the details rather quickly. The first one is a very small study, and that's a real limitation of this, but it is based in Sweden. It's part of the Swedish Twin Registry, where they have excellent, zygosity testing, clinical measures of autism, and at my request, they started collecting some teeth. We only have 76 participants in this study, but that's about a quarter of the whole cohort. And if you look at the tooth shedding age, that's about 50%. And we analyze these teeth using our laser ablation platform. Now, this is the DLM, or the distributed lag model, that I mentioned earlier when I showed that dynamic graph of manganese. Because it's a busy graph, I'll build this slowly. We're looking at zinc and its relationship to autism spectrum disorder diagnosis, but within twins. So this comparison is within siblings. On the x-axis, we have our temporal profile. So we go from about minus 20 weeks to plus 30 weeks at a week-by-week resolution. And on the horizontal axis, where it is 0, that means we have no difference between cases and controls. Above that, the line indicates that cases have more. Below that, cases have less. So our black line is our distributed lag model. Beyond that, we have two sets of adjustments. One is an adjustment for twinship, because they're all siblings, so we have like a clustering effect there, and also our 95% confidence intervals. I work with Chris Jennings, who many of you know, who's very conservative, very careful, and she applied a further correction, a Bonferroni adjustment, because we are comparing many metals at many times. So those are the vertical gray bars. Now, if we follow this entire band, we see that we have a significant association from about minus 10 weeks to about plus 4 weeks, and that is that critical window. That is, if I were to make a dynamic graph, that's where it would dip below and then go back out again. Again, I make the same point I made before. If you grind up whole teeth and get one number, the whole association would be missed, and this would appear as a null association. But in fact, what we found here in zinc has been shown in animal models later on as well. So this association seems to be holding up. Like I said, that was a very small study, and how many of us have a twin case or control matched to us? So we wanted to replicate this, and we took this replication in 3 different clinical centers in the UK, in the ALSPAC study, in New York, where we had siblings, and in Texas, where we had population-based recruitment through social media. The other interesting thing that we purposely did here, by recruiting the UK cohort who were born around the 1990s, we had a shift in almost more than a decade in exposure history, exposure profiles. They would be more likely have a lead exposure than children who were born in Sweden more recently, for example. Overall, we had 193 participants. This table will be in the slides, but I won't go through into this. But each study on its own is small, but together it's a modest size. That entire dysregulation I showed you with zinc, we also observed that with multiple other elements. So we created our own index. We call it a metal regulation or a metal dysregulation index. The higher the number here, the more regular your metal dynamics. So in Sweden, we see that controls have a more regulated multi-elemental dynamic than these cases that are in the orange square. We saw the same pattern in our own study here at Mount Sinai, the same in Texas, and the same in the UK. We have gone from twins to non-twin siblings to population level unrelated participants, and this study includes participants who were born over a spread of about 2 decades. So all this seemed to confirm our replication. Excuse me. And when we do the pooled analysis, that was significant as well. However, I keep seeing these newer machine learning applications that form clusters, and I'm not only concerned about replication of the findings, but also that to see a real biomarker of disease, we don't just need to separate it from controls, we also need to separate it from the next nearest disease. And in autism, one of the other phenotypes that often gets confused for autism is ADHD. So here what you see in pink is our controls. In orange are cases that only have autism. In green, we have ADHD cases alone, and then in the blue, we have those that are comorbid. And you can see how our algorithm is very good at separating them and forming these clusters. So this has a lot of implications for precision environmental medicine, because each individual is defined in terms of their phenotype, not just based on the clinical measure, but based on their molecular or their exposomic measure. Okay, so we talked about metals. I've given you some information on various organic exposures. But like I said before, we want to build these pathway models. We really want to measure molecular phenotypes in terms of biological response. One of the most common responses that we encounter in our literature on autism and many other conditions, of course, is inflammation. It took us about 4 years to develop this. This has been a real effort. But here's the tooth. As I said, there are growth rings in teeth. And now you can see some. Only these growth rings are periods of high inflammation. And as far as I know, this is the first time someone has directly measured fetal inflammation at a day-to-day resolution. The y-axis label has somehow dropped off, but that's the intensity of our inflammatory markers. It's a whole bunch of different cytokines and inflammatory proteins brought together here. It's a multiplexed assay. What you will see here is that we have not some steady state of inflammation, but inflammation overall shows wild fluctuations. And it appears that that is the norm. Before I saw this data, I always assumed that there was some homeostatic profile of inflammation. But now I'm more and more thinking that it's a very dynamic profile of inflammation, even during fetal development. So this was really exciting, but what is the clinical relevance of this? So very quickly, again, we went back to our Swedish cohort and started studying autism spectrum disorder. And this is the distributed lag model that I introduced earlier. And what we see is that the intensity of inflammation is higher in cases, but there are two critical windows for that. One is entirely prenatally in the third trimester, and one is postnatally around day 170, day 200. There's a lot of interest in the third trimester as a critical window for autism. We ourselves found that there was zinc dysregulation. There are studies on air pollution showing that third trimester might be a critical window. So all of this seems to be fitting well into that picture. But again, our twin study is a small sample size, so we went and replicated that in our Texas cohort that I had mentioned earlier. This is not a twin study. These are unrelated population-based participants. Here again, we see that we can replicate that prenatal window of or critical window in relation to autism. However, there is one limitation of this study, and that is that we don't have time points after the age of 100. Moving on from this. So that was a very quick look at our work on autism spectrum disorder, and as a way of introducing how we can measure many different things, all from a single tooth sample. We have measured metals, we have measured metabolomic signatures, organic targets, as well as biological response targets. But still, we haven't answered that question. How do we overcome the issues of a very long lag in a rare condition? So let me, in the last 5 minutes, go to ALS or Lou Gehrig's disease. The person on the left is Lou Gehrig. That's why in the US it's often referred to by that name. The person on the right is the late physicist Stephen Hawking, and there's some controversy whether he had ALS or some other kind of motor neuron disease, but generally he's believed to have ALS. Now this is a very small study, and I want to acknowledge my collaborators at the University of Michigan who have been excellent collaborators and really collected all the clinical data that I'm about to show. The thing with ALS is it's a really complicated disease because we don't know much about it. All we know is that heritability is very low, less than 10%. The few mutations that we have found in ALS account for a very small amount of the disease. So majority of that is suspected to be an environmentally driven disease. We do suspect early life exposure, but how do we go back 50 years in this case? That's the average age of diagnosis, and figure out what happened around birth. In this study, we only had 36 cases and 31 controls. It was published recently as 2 papers. But the average age of our participants is 60. And what I'm going to show you next is how we reconstruct week by week exposures. So far, we've only done elements and toxic metals here, but we plan to do the organics next. Again, I want to acknowledge Chris Jennings for the wonderful statistical methods she has developed. The panel A I show here is an improvement on the distributed lag models by combining it with her method, which is the weighted quantile sum regression, and we call it the lag WQS. In essence, it models the entire metal mixture. Each individual metal is shown here, but this gray graph, we are seeing the whole mixture modeled as a function of time from birth to 15 years. So that's 15 years of a person's history reconstructed at a week-by-week resolution. That's like saying we have 500 sequential measurements taken in blood, which I think would be next to impossible to do in a large epidemiologic study. What we see here is that even at birth, we are seeing this dysregulation in elements. Again, we see a second window here between the ages of about 6 and 10, and then a third window around the age of 13 and older. But the neat thing about Chris's methods is we don't have to look at the whole mixture as one. We can also look at the contribution of each element to that relationship. And you will see that early on, they're all affected, but later on, different elements are impacted differently in this disease. And that is very interesting to start to understand biological pathways and when they are impacted at different critical windows or different stages of development. Also want to acknowledge one of my other colleagues, Paul Curtin, who works closely with Christine Austin. Both are faculty in our department. We're not just using novel biostatistical methods, but we are really adopting AI methods. And he's developed this new pattern recognition algorithm. I won't go into details and try to explain this, but it's evident just by looking at them that controls in ALS look very different to cases. And that's all I'm going to say. But again, this is something that we are excited about. We believe it will have implications for precision environmental medicine. I'm almost out of time, so I'll conclude again by just going over the vision we have and how we can, how this technology can contribute to large studies like ECHO, and we are collaborating with several national studies now. What we see here is the challenge. On the x-axis is the challenge that most environmental chemicals are present at very low amounts. But with newer mass spec methods, we are able to detect them reliably. But environmental exposures, measuring them and just correlating them to a clinical phenotype is not the kind of epidemiology we need anymore. We can do more than that. We can measure many different kinds of exposures, their metabolites, and then create this map of our molecular phenotype. And that we shouldn't forget the microbiome. Recently, we published a paper with Andrea Cassidy Bushro at Henry Ford on how early life metal exposure as measured in teeth actually will impact the type of microbiome your gut adopts even at birth. Having said all that, I will end by just acknowledging a few folks who have really been very supportive, especially my department chairman, Bob Wright. I won't read out all these names, but I do want to acknowledge the funding, both for the here targeted and untargeted centers that are at Mount Sinai, and for the R35 or River program that allows me the freedom to often innovate in these areas which are not possible through traditional grant mechanisms. Chris, Carcieta, and Katie, again, thank you for organizing this. I'm happy to take any questions.
That was terrific, Manish. Let me turn the conversation over to Bob Wright from the Sinai School of Medicine. Bob?
Thank you. Great talk, Manish. Really, your method allows for researchers to discover where the critical windows are, which is incredibly novel because if you do a prospective study, in essence, you're guessing when you have to biosample in order to capture the critical window, and there's an expense to these multiple visits that goes even beyond just the assay. So what the work really does is add this extra dimension to epi research with regards to replication, because not only are you replicating the chemicals, particularly for exposomics, that are involved in predicting the health outcome, but you really should be replicating the critical window. You did that with autism using the tooth, but with regards to replicating the window, have you done any work trying to replicate the time boundaries of the clinical window using a more traditional biomatrix, for example, blood lead, rather than only using teeth?
That's a very good point, and I'll start off by addressing the general conceptual problem here. That you're exactly right. One application of teeth that is often, I think, underappreciated is that if we were to use them in a subset of our, let's say, our echo participants or any large cohort, we could pick up the critical window, and that's where we would. Those are the samples, and we would analyze for using blood and urine and using traditional markers, because A, you would have a capture on the critical window, and B, there would be a far more efficient design in focusing on that window. So this could only be almost be used as a microscope of sorts to find the right time period of when to study. Going back to your question, yes, so we have used traditional biomarkers, both blood and urine. Blood has been done for lead and manganese, both in animal studies and in human models. And in one study, for example, we found that there was this shift from a positive association prenatally, that was for manganese and neurodevelopment, but an inverse association soon after birth. We were able to replicate this in a completely unrelated cohort in Italy, and in a different measure of neurodevelopment as well. And in both cases, the interesting finding was we saw the same gender difference. And that was really interesting to not just replicate the finding of the metal versus the neurodevelopmental health outcome, but to see the same sex difference in two completely different populations. So yes, some of it has been replicated. That approach has been used, but I think much more can be done.
Thank you.
Thanks. And how about Andrea Cassidy?
Yes, excellent talk. Very enjoyable and exciting to see the new methodologies that you're developing. I had a sort of a broad question related to thinking of how some of the echo cohorts are now probably beyond their typical tooth shedding years, and whether or not there would be any application, sort of thinking of the first 1,000 years or first 1,000 days of life with using wisdom teeth to do any of this type of work.
Absolutely. So the ALS study that I presented, many of them were wisdom teeth. All of them were permanent teeth. One thing in ALS is often as you lose motor control, you have trouble, looking after your oral hygiene. So if you only have a few teeth left, they're often removed. So collection there was easier. I mentioned two other points here. I found in the U.S. and several other countries where I collaborate, there's a tradition to keeping baby teeth. So if you have a 16, 17-year-old, cohort of participants where the average age is around that, I think the parents will have teeth for about 50 to 60% of the kids. That's what I'm seeing. So we shouldn't give up on baby teeth if the children are past the age of shedding. The other thing is there are other opportunities to collect teeth. For example, often orthodontists will remove the premolars to create some space to realign the crooked or crowded teeth. So again, there are these programs through dental offices that I have participated in where we do get teeth. Then again, as you mentioned, wisdom teeth removal is quite common these days. So this technology is not just for baby teeth. I think getting permanent teeth is very doable, and it certainly can be, and we have certainly done it. And so I'm fully supportive of it.
Great. Well, thank you, Andrea. Thanks, Bob. And Manish, we have some questions in the chat box. Some are short, and I'll read those. Others are a little bit longer, and we'll ask folks to expand on that. So the first is from Bill Pfeiffer. Bill, do you want to just ask your question orally?
Sure. Thank you again, Manish. What I said in the chat was, again, I'm so impressed with the effort that you've been continuing to carry out and getting such meaningful results. My question had to do with, particularly with the autism story, where I think you had mentioned in the Swedish cohort that you didn't have access to data after 100 days or so. I wondered why that was, and two, given the importance that I know, as you know, of repeated inflammatory events as being part of the risk profile for autism, I'm wondering if there's a problem with doing that, if it's a relative peaks that you have to get for inflammatory processes against the background. I just didn't understand why we might not have more information on postnatal markers.
Absolutely, and just to correct the assumption that it's only up to 100 days. That is not correct. In fact, in the Swedish cohort, we have measures up to 400 days. It's just currently our data is quite sparse. This is an early project for us. For metals, we can measure them up to much later in life, up to tooth shedding. And we have published that paper in 2014. We've shown that those metals hold. Those measures reflect exposure. For inflammation, we have to be careful. One of the common misconceptions about teeth is that people ignore local kinetics, just like we ignore the local kinetics in other biomatrices. When we first started measuring lead in blood, we would just measure whole lead blood, and we realized, well, most of the lead in the RBCs is not what is, interacting with the target tissues. It's the lead in the serum, and so we started accounting for blood lead kinetics. The same way, teeth are in organs, there is local kinetics. To return back to your question, we can certainly measure inflammation up to 300-400 days after birth. So we can cover the first year. Beyond that, we are working on it. We are concerned how much of that signature will be corrupted by more recent events and due to tooth remodeling. And I don't have a clear picture on that, to be perfectly honest.
Thanks.
Thanks, Bill. Lisa Crowan asked, what analytes are included in your inflammation assay?
So we have a bunch of cytokines, interleukins, global markers like C-reactive protein. Yeah.
Lisa, does that answer your question, or do you want more detail?
No, that's great. Thanks very much, Manish.
Okay, sure.
Super. And I don't know last name, but Kristen was asking, wondering whether the untargeted analytes are obtained as background in targeted runs, say for metals, or are these performed as separate assays using additional samples?
No. So to answer, they're separate assays, but they're from the same tooth. And that's why, I made this point about developing our own hardware, because, and I've done this myself, when I first started, the gold standard, or whatever you want to call it, the method was to grind up whole teeth. And there were methods where you ground down the tooth to a thin wafer, and you pretty much lost 90% of the tooth, and you just left with this nice thin wafer, which is great under the microscope, but you've just, wasted a precious tissue that cannot be replaced. So, no, it's not the same assay, but it's the same tooth sample, with the caveat that if you send me a very broken, fragmented tooth, I'll ask you for a different one. It has to be a good-looking tooth.
Good. Matt Gilman asks, could you please talk about replication of your methodology and approach? What other labs have done similar work? Do they get similar findings?
For the metals assay, which yes. For some of the other assays, they're fairly new, so I don't know who else is doing them. I honestly don't. But for the metals assay, yes, absolutely. So we invited a scientist over as part of an agreement with a national lab, and we trained the scientists for a whole year. Now we are helping them set up their lab, building robots for them as part of that organization's agreement with Mount Sinai, and then we are analyzing the same samples at two labs, we spent the last several years building our own synthetic standards to have something that looks like a NIST standard, but obviously NIST doesn't have a tooth standard. So we have our own standard that look like a tooth. They're not just some compressed powder or something like that. So very much we are interested in quality control, not just in our lab, but to make sure that other labs get the same answer, and we are seeing that. Mount Sinai is setting up its own lab outside the Mount Sinai system in collaboration with the private sector. That's a very big lab which will have the tooth biomarker. It'll be starting in June. That'll have more than 10 to 15 mass specs, and that's to service national studies overseas that have already asked for us to analyze teeth for them in the tens of thousands. So then there'll be 3 labs that are doing this, and that's a good number to start around, Robin. And initial results are very encouraging for metals, but in all honesty, for like the inflammatory marker, that's very new. So it's too early to start doing PT. We need to really publish some findings with health outcomes, understand what that means better before we start saying, well, let's see what other people are doing.
So Manish, this is my question. Let's say I'm an echo investigator and I'm really intrigued with this methodology. What are my steps? Is there a reference that I can go to or a set of references to see what are the options for measurement? Do we just steer people to you? How can I go about thinking through the approach for integrating this kind of assessment into my cohort studies?
Absolutely. So I'm PI of a untargeted lab hub, and Dr. Bob Wright is the PI of a here targeted lab hub. So the metals are offered because they're high throughput. They're offered through the HERE program. And ECHO, of course, has a collaboration with HERE, and they have ECHO supplements. So you can get your teeth analyzed for metals. You already know that we'll be doing some through that mechanism. I'm collaborating actively with various ECHO projects measuring metals and organics. I'm part of the autism consortium that's led by Craig Newshafer and several others. So I'm already part of the ECHO mechanism as well as a service provider. Beyond that, just drop me an email. The easiest thing to do is just have a quick phone call and discuss your specific needs and then see what's possible within ECHO and what's possible outside ECHO. Personally, my vision is that once we have several thousand participants analyzed in a consistent manner with good QA/QC, we'll start seeing patterns that we haven't seen before. Because really we have focused on measuring many things. What I'm proposing is measuring things at many times. So that goes back to my introductory slide. We look at it as G by E, but E is not just many things. It's got to have the time component. And I hope we get there, that we can measure 10,000 teeth in multiple cohorts around the world. I just look forward to the day when the data scientists start doing something amazing with that data.
Big data with teeth. And Doug Walker, I see, is part of the list of participants. And I wonder, Doug, whether there are any comments that you'd like to make or questions that you have from Manish.
Thank you, Manish. I thought that was a fantastic presentation. I really feel like we're in the beginning stages of being able to unlock the environmental biodynamics, as you said, and time is such a critical component of understanding how exposures influence our health. One thing that I was a little curious about is, especially for the in utero exposures, is what you suspect the primary form of exposure is. Or are these compounds that are present in amniotic fluid, or is it somehow in the fetus's blood? And my second question is, we know that amniotic fluid changes over the course of pregnancy. So how could that composition of the amniotic fluid influence deposition of exposures in the teeth?
Look, this is an excellent question. Much of what we are seeing and much of our validation work has been against mother's blood, obviously then the fetal circulation and that comes into play. And we've also, compared tooth metals, especially in some organics, in teeth versus cord blood. So far, that's where our effort has been. To answer your question about amniotic fluid, I'm going to have to guess because we haven't compared it to measures in amniotic fluid. We just haven't been part of studies where that is easily available. Having said that, when teeth start mineralizing, at least the parts that we focus on analyzing start locking away very quickly. So once they get mineralized, there's not a whole lot of exchange happening. And that is the reason why we analyze this very narrow band of tooth material. You know, the teeth are pretty big and bulky, but most of that we don't analyze. So I don't think the amniotic fluid is going to have a lot of interaction. I wouldn't be surprised if there's some, but that's the best I can answer right now. If you are part of cohorts where the children are at tooth shedding age now, they have teeth from previous collections and they have amniotic fluid, I'd love to be part of that study.
Thanks, Manish. And Amy, I'm not sure I understand the abbreviation in your note. Maybe you could just expand on your comment on the 1,094 participants.
Oh, sure. Thanks for a great talk. By the way, this is Amy Elliott in South Dakota. I was just curious of how well ECHO was doing at collecting teeth, and I just realized these may not be participants, but currently there's 1,094 teeth that are attractive being already obtained, and that's through the ECHO-wide Common Protocol. And it looks like almost a little shy of 800 have already been transferred to the repository. So that's where we're at currently in terms of ECHO collecting of teeth.
Yes, no, that's very encouraging. You know, I think we can easily double or triple that number, or actually much more than that, given that we'll have 50,000 participants. Just to quickly weigh in on that, there were recent discussions by the ECHO Chemical Working Group, and we have to balance, priorities. So I'm glad teeth are there, teeth are stable at room temperature. I'll leave it to ECHO leadership to decide when is the right time and what are the targets. What we are seeing in our own studies in terms of high priority health outcomes like autism that I have discussed is quite encouraging. I think it's a resource worth investing in, but obviously that is a biased opinion because this is what I do. But thank you, Amy, for sharing that. It's very encouraging to see that we have almost 1,000 teeth now.
Yeah, and thank you, Amy, for letting me know what that abbreviation stands for. Now I get it. And I'm going to make one last comment, and Manish, I'm going to leave you with the one final question. As we pivot into 2021 and later, Echo Discovery is going to have a spotlight on diversity and equity, and so we'll be asking speakers to address those issues in their talks. And so I wonder, Manish, have there been studies using tooth analyses that have detected disparities due to socially determined characteristics like race, ethnicity, socioeconomic status, et cetera?
Absolutely. Work with Andrea Cassidy-Beshreau has shown that. I'm working with the teeth from the Flint water crisis, and it might sound like I'm bragging, but there was a 60-minute special using the tooth biomarkers. I made a cameo appearance for like 10 seconds, but Dr. Mona Hanna-Attisha was she's the champion there leading that, and we're honored to help with that. Jill Johnston at the University of Southern California has done these beautiful studies. She calls them the Truth Fairy studies in this community where it's just unbelievable that industry has actively dumped lead waste next to housing from a factory project. And we found these unbelievable levels of lead in those children's teeth. We even correlated it to the soil levels, and it correlates very well. We created a community feedback report for the tooth biomarker, showing how much lead are there in those children's teeth relative to other cohorts that I have studied. I'll just say this one point that we see higher levels of lead in children's teeth before they are born, and that injustice is inherited from prior generations, right? Because it's embedded in the bones and it then gets transferred. I wouldn't be happy if my father's bank loan was transferred to me before I was born, but somehow we all seem to accept this, that it's okay for an unborn fetus to bear the the environmental injustice of their mother and their mother's mother and just that entire community. So yes, there is data. There's been pushback against those papers as well. If you read some of those comments, they're not the nicest comments that some people have left against those papers. But I'll be very happy to support that work in any way I can.
Well, on behalf of EcoDiscovery, Manish, thank you for an excellent talk and educating us about tooth and tantalizing our interest in biodynamic interfaces. I've already downloaded a couple of your papers, and I would encourage others to read some of his work in bioessays. Really terrific stuff. Thanks so much for this great talk. And Carcietta, if you want to advance, do we have a next talk slide? Yes. Everybody, please do, if you when you get the link, please do respond to our evaluation survey. We use that information. We take it very seriously. And then our upcoming EcoDiscovery presentation on February 10th will be Michael O'Shea and Rebecca Fry. The title of their presentation is Early Life Origins of Health Among Individuals Born Extremely Premature. Have a terrific day, everybody. And again, thank you so much, Dr. Arora, for a terrific talk.